Tulsi, you're in the office?
I'm the office, yeah.
Okay.
Yeah.
How are things in Madurai?
Madurai, things seems to be under control. I think all of Tamil Nadu seems to be that way on the decline. So hopefully it's all reality and not a maya of reporting. Yeah. But either way, I think it's good news. Yeah.
That's good news. Yes, absolutely.
Yeah. If you don't have it, it is good news. If it is there, also it's good news.
I think we could begin.
Oh, we are up to 70 attendees right now.
And YouTube also. Should we wait or start?
Maybe just 2 more minutes.
Okay, fine. So shall we begin? Yeah.
Yeah, let's begin.
Yeah. Good evening, everyone. Welcome to this webinar on technology for universal eye health. The World Health Organization defines universal eye health coverage and therefore universal eye health through integrated people-centered eye care for all of humanity. Health technologies equip us with tools that are indispensable for effective and efficient prevention, diagnosis, treatment, and rehabilitation, and therefore the attainment of health-related goals. According to a recent Forbes study, digital technologies are constantly evolving and finding new applications in healthcare. The top three innovations identified were big data analytics, artificial intelligence, and mHealth, that is mobile based virtual healthcare. Most of us are familiar with the latter in the form of teleophthalmology. The Government of India's National Programme for Control of Blindness, the National Health Policy, and the UN SDGs recognize the integral role of affordable technology for improving the efficiency and outcomes of the healthcare system. Mission for Vision's own journey over the past 20 years has experienced the power of harnessing technology, whether it's for strengthening eye health systems or measuring the impact of our work and in generating evidence from it. We also acknowledge and appreciate all of our partners' efforts and innovations towards this. The value of technology is becoming even more obvious and significant during these COVID-19 times. This webinar is to reiterate the value of technology for eye health for all. Its timing has been deliberately set to align with the year 2020 and the celebrations this month. It is intended to share examples of good practice in technology-enabled eye health care and stimulate ideas for the future. We are very honored to have with us eminent personalities to share their rich experience and wisdom with us, each of them a leader in his or her domain. It's all the more special as Vision for Vision partners with all of them. Please join me in welcoming Mr. R.D. Tulsiraj, Ms. Rajeshri Natarajan, Mr. Bharat Balasubramaniam, and Mr. Veer Rajshekhar. We will have an opportunity for a question and answer and discussion session at the end. We will begin with the keynote address. Mr. R.D. Tulsiraj. Mr. Tulsiraj needs no introduction. He is a founding member of the Aravind Eye Care System and integral to its leadership team. He is currently the Director of Operations for Aravind Eye Care System and Executive Director of the Lions Aravind Institute of Community Ophthalmology, or LICO as we know it. With a keen focus on capacity building and management training, LICO has mentored and shared best practice with over 350 hospitals in India and 28 other countries. Mr. Tulsiraj has served as an advisor on several national and international bodies and was a founder president of Vision 2020, the Right to Sight India. He has also been technical advisor to India's National Programme for the Control of Blindness and the World Health Organization. Listed among the 30 most influential people in public health globally, Mr. Tulsiraj's contribution to the field of eye care and its management has been well recognized through the various awards and titles he has received over the years. Mr. Tulsiraj, may I request you to please honor us with the keynote address on the importance of technology for universal eye health.
Thank you. Thank you, Elizabeth. I just get the technology going.
Yes, sure.
Okay, I guess you're seeing the slides now.
Very clearly, thank you.
Okay. Thank you, Elizabeth, and for the team at Mission for Vision. And good afternoon, good morning, good evening to the participants. I recognize people could be from all over the place. I would like to give a high-level paradigm relating to universal eye health and technology. In doing so, I think the very first thing for us to recognize is what is meant by universal health or universal eye health in our context. I think it's been fairly well defined in simple terms. Now, one is about making sure there is um, access to everyone. That is, everyone can, without any discrimination, can access healthcare. And the healthcare provided is comprehensive. It is not just not dealing with one aspect or the other. It is comprehensive in terms of owning through referrals through whatever mechanisms. And the third most important point is that in doing so, in accessing and getting care, they're not getting bankrupt because it has been recognized that healthcare is probably accountable for more than a third of people slipping into poverty, especially the catastrophic expenses. So this is high level understanding of what we mean by universal health. Second, I just wanted to give a little bit of a background about the current scenario for eye care. And I was struggling to find the right kind of a graphic, and then I landed upon my most favorite cartoon character. I still fight with my grandchildren for Asterix and Obelix comics. So just as Obelix is depicted here, the healthcare in most part of the world, including in India, is very heavy in the middle. That is, it is largely secondary eye care that exists. And then that gave birth to a few tertiary eye care. So for most part, eye care in India consists of secondary and tertiary. Not only India, I think this applies to almost all countries, I would say. And then these two, the tertiary and secondary centers, are now kind of seeding some primary eye care. Now it is there, but it is not in any significant level because a lot of the eye care still tends to be provided by secondary care and then to some extent by tertiary centers. The second paradigm about eye care is that it is largely reactive, in the sense it deals with people who come to the hospital or to an eye camp. And those who come, they do diagnosis, and it is not always comprehensive for multiple reasons. And then once they diagnose and prescribe something, it is left to the patient to comply. And then those who comply would get treatment. So this is the current paradigm. And again, it's important for us to understand in the context of can technology help in this. And then another character of eye care is that we have been largely dealing with episodic care, like cataract surgery or red eye or glasses and things like that. So that's where a lot of the competence, technology, and processes today are. But then we are recognizing that increasingly we also have to do chronic care, especially relating to glaucoma or the diabetic retinopathy. India is, I think, already the global capital for diabetes, and all of them require lifelong monitoring for eye care. So these are some of the characteristics. So what we need to kind of address the goal of universal eye health is to have timely case finding, which covers everyone, that is universal. And then how do we make sure compliance, not only to chronic care, but also for whatever diagnosis and treatment is advised. Then how can we integrate with the other levels of care, in a way that we actually create synergy and not kind of forcing a misfit. And then when we think about it, we can recognize that especially the first point, which is the starting level for universal eye health, is case finding. I think this can happen best as we go down to the community level. Because sitting in a hospital, secondary or tertiary, we are not designed for universal health. We can only deal with those who come to us. If you really want universal health, we need to go down to the community level. which is why I'm kind of arguing that primary eye care or vision centers offers a possibility. And what this model has, which has got a few key elements, is one with a primary eye care center or a vision center, we can bring about a denominator focus, of actually defining what the service area is and actually keeping track whether we're able to deal with everyone in that population. And then with the right technology and protocols, one can bring about comprehensive and quality eye examination. And then closing the loop again is possible, both by way of design and also enabling patient compliance. And of course, one of the challenge that we have where technology can help is to enable remote management of such facilities, because they will all be in remote and they'll also be in very large numbers. So I'm just giving an example of the possibility of universal coverage. If we take a population of 50,000, which is typically what is covered by a vision center or primary care, and if you assume that 1 in 4 persons, that is roughly 1 in every family or 25% of the population, will need eye care, that translates to about 12,500. And if we need to achieve a cataract surgical rate of 10,000, which is the goal, that means there are 500 cataract surgeries to be done each year from that 50,000 population. And similarly, glasses, which is more required. Everyone above 40, 45 requires a pair of glasses. And if you assume they will change it once in 5 years, we need to provide about 2,000 eyeglasses each year. And then ongoing regular annual care for glaucoma patients and diabetic patients. These are based on certain rule of thumb. And if you look at what has been the impact of this, based on our experience of vision centers, we have about close to 80 vision centers now, covering a population of close to 7 million. And then this is an average. Some centers are very new, within a year, but on average, we have registered within this 50,000 more than 10,000 patients, unique patients, about 84, 85% coverage. If we calculate the surgeries done that we're able to track from the vision centers against a target of 500, we have achieved around 300. If you take glasses against a target of 2,000, our annual dispensing is around 450, even though it is 23 or 25%, 1/4. I think the denominator was much, much, much lower. So in terms of penetration, it is several fold than what it was prior to having the vision centers. And similarly for glaucoma and diabetes, these numbers are very significant, even though they are in the 40s, because in glaucoma, I think the discovery rate is in single digit in the population base, but the vision center are able to drive it up significantly, and over time, I'm quite confident that we will eventually get to universal health in terms of comprehensively covering all conditions. So this is a summation of the work done till now against the 7 million people that we are covering now. We have roughly 27% of the population have registered with us. These are unique patients. So we kind of feel that we are pretty close to have reached everyone, or at least we are certainly reachable for everyone. So, and then of those who came, more than a fourth of them either got a cataract surgery or a pair of glasses. So we're also able to recognize that there is this element of closing the loop, which again is at a high level. So in all this, I think there are a few enablers. One, I think, is a care design, which has to shift from being reactive to proactive. And then this is possible in a primary care setup. And it's also possible in second and tertiary as well, because I think this stems out of our mindset of wanting to close the loop, care loop, from finding cases to making sure they get the treatment and then making sure it also works with follow-up. And that requires owning the problem and a can-do attitude. And it also requires a denominator-driven kind of a design process. Because I think by over the decades, we have basically been numerator-driven, because none of the hospital reports would say what proportion of the work they have done. It will always say we have seen so many patients or done so many surgeries. What we report is only the numerator. And then we also require technology, and which will be the focus of my this workshop and the rest of the few slides that I will be running through. So the technology is needed, I think, pretty much across the whole eye care. It is required in the care delivery. I think technologies can do a lot in enabling and improving process. And then it can also help in monitoring. And without monitoring, there is no way we can be sure that we are moving towards universal eye health. So there are certain considerations that we need to keep in mind, especially if you're looking at primary level, because as we go down the ladder in providing care, we also have to recognize that the scale also reduces. Now, because a secondary level hospital is set up usually for a population of 500,000 to 1 million. So that gives you a certain scale, which can allow you to make certain investments in technology and so on. But that won't be the case when it goes down to a level of 50,000. And then when you go down to smaller scale, you also have other challenges in terms of the level of staffing, the type of staffing, their competence, the local infrastructure, power available, not available, the support structure that is there or not there. So the technology will need to be very robust, very reliable, idiot-proof, simple to learn and use, and also very inexpensive if you are going to scale. Because I don't think we can scale purely dependent on donations, and so it is also has to make a bit of a business sense for us to be able to scale. So I'll just run through some examples. Today we feel one of the big bottlenecks, I think all of us will recognize, is human resource in terms of their skills and competency. And if they have to get refraction happening at eye camps or at village level, the immediate bottleneck is not having an optometrist who's willing to go there, or not having someone who's very good in refraction there. So refraction service, which is really simple, it was so simple that till a few years ago, WHO didn't even think it was a problem, because their own definition was of blindness or visual impairment was best corrected vision, because they assume it's such a simple thing to do. But then that is possibly one of the least served areas. So things like now we have portable auto refractors, which I think studies have shown to be as good as the current gold standard, which is an optometrist doing a subjective refraction in a hospital setting. The same can be achieved by someone being trained for a couple of hours to take a reading out of a device like what I have shown. And these are emerging, and these have a lot of built-in technologies which kind of leverage the advancements in digital technology and chip manufacturing and so on. Another big thing that we have is, as we go down, we cannot bring the skills to every level. Even if you have telemedicine, there are some limitations to it. When we find that diabetes is at the level of 4 or 5% in the general population, how does one make sure that good diagnosis happens? And this is a work that we have done with Google. I'll just run this video if I get to it. Yeah. So you just have to drag and drop an image in the circle, and it takes about 10, 15 seconds where the analysis happens in the cloud. And then you get a pretty detailed diagnosis where this has been checked against the gold standard with about 97% plus accuracy and very, very high level of consistency as opposed to uh, retina specialist grading images where there's consistency only at the edges, at the definite retinopathy and the definite normals. In between, they're all over the place, but a technology like this makes it very, very consistent. So these are what they call as use. You don't need any investment in the vision centers to make this happen, other than having internet and a computer in which we can upload these images. So it makes it amenable for deployment at all levels. Another very important piece, which is not like earth-shattering technology, is electronic medical records with associated things that we have, and we built one 15 years back, to make sure that our vision centers are supported with telemedicine, and then for any telemedicine, electronic medical record forms the backbone, so that collaboration can happen at both levels. Simultaneously, the doctor can see the records as much as the technician sees it. And then with that, they're able to make a prescription of glasses or for medicines, which also kind of circumvent some of the gray areas, because today the policies haven't caught up with the technology. So today, but the doctor is authorized to give a prescription and technology can enable it. And then once you have a prescription and then you have your inventory and the billing, sale of medicines or glasses, everything brought into one system, it can seamlessly integrate inventory management, supply chain, financial accounting. All of that can happen through a single application. And all of these are important. I mean, they're not rocket science technologies, but without that, your whole process fails. You know? And then it can help quite a lot in reducing administrative work, which is not to be trivialized. Things like digital payments. It is just catching on in India. Probably today around 15, 20, 25% of the payments are digital, I think. But in the bigger cities, in urban areas, people are much more conversant with this, from auto rickshaw drivers to street vendors. Everybody's got a QR code for making digital payments. And then I think something which cannot be done manually is enforcing best practice. Today, technologies allow us to do that. With an EMR, we can actually mandate certain practices which you're not able to do with paper records. So we can assure a better safety and better quality in the clinical work that happens. And that automatically also is capable of giving us real-time data, which can help us to manage the exception. I think this becomes increasingly critical. In the past, I don't think this notion existed, because our management used to be by knowing what's going on. So really we're not managing, we just know what is happening. But with the digital technologies, we can actually figure out what is not happening that should have happened. And then our attention can be drawn to that. And all of this requires investing in IT infrastructure, which I think many hospitals do recognize now. And the technology also now allows shifting tasks to the customer, patients in our case. We recognize this has happened to a large measure in banking or in railways or in airlines, where now the customer does a lot of the work which otherwise the industry had to invest to do. And then now we have a possibility of replicating this also in the hospital. Before the patient comes to the hospital, they can do the registration, They can give the history probably much better than what we can take in the hospital setting. Now, if they have an insurance, they can fill in all the details. And depending on their condition, we can push the health education material. So the patient, when they come to the hospital, has given us a lot of the details, as well as has a certain level of empowerment to understand what goes on in the hospital. And within the hospital, we have a good app that can talk to the EMR. Now, you can help a lot. Patient doesn't need to be told where to go. The device can tell the patient. It can tell the patient what to expect next, how long it will take, give them the results of investigations, digital payment, and so on. So you can recognize with good technology deployment, we can significantly bring down the effort in the hospital in a way that patient enjoys it, the patient would want that. So in conclusion, I recognize that there are already, all that I have mentioned is not new technology. They're all already out there, and they're all waiting to be adopted. So it just requires our own imagination and innovation. And at the same time, there are areas for which we need new technologies. And it is for us to articulate those use case scenarios and challenge the technology people. And there's a lot of hunger in the technology world for such challenges, which are really meaningful. Because today the scenario is in the technology field, there is so much of innovation out there now looking for a problem. And I think we can change that and put it to good use. Thank you very much.
Thank you so much, Tulsi. Thank you so much for that excellent overview and for emphasizing the need to prioritize in terms of access for people, access to primary eye health, and therefore technology enabled primary eye health. Because primary eye care, as we know, is fundamental to reaching out to the remotest corners of the country and ensuring access for all. Thank you for also urging us to think more of chronic care and to, develop a more proactive approach rather than being reactive always. And also for sharing with us wonderful technology from the Arvind's experience, in terms of enabling systems that are robust, reliable, and inexpensive to communities. And more importantly, also in terms of shifting the onus more on the beneficiaries and respecting their intelligence and capabilities as well. Thank you so much. Ms. Rajeshri Natarajan. Ms. Rajeshri Natarajan has been an IT industry veteran with a social impact leader for over 30 years. As the global head of process and platforms at Cognizant Technology, she was responsible for developing cutting-edge technology solutions and incubating new product ventures that support global delivery. Ms. Natarajan is currently the Chief Executive Officer for Cognizant Foundation and plays a key role in evolving an overarching charter for the foundation, defining CSR strategies and goals, including for eye health, managing operations, communications, and relationships with a broad set of diverse stakeholders. Ms. Natarajan, we look forward to your message on leveraging technology for health and development. Thank you for joining us.
Thank you, Ms. Kurian. It's been wonderful listening and being part of this panel, and thanks for Mr. Tulsi for a wonderful, very inspiring talk and a keynote. I'll just give you a brief about Cognizant Foundation and what we do, and then why this cause is actually so important for us. And of course, like many others, as part of our corporate responsibility, we started focusing on a few things. We just thought healthcare and education should be our two pillars. But we started with like a little bit of 15 years back, we started our journey. We started doing small projects for multiple causes. Then we realized that there is actually a very strong case for focusing our effort towards avoiding blindness, particularly a kind of for the vision care. Obviously we all know in terms of the data that, India has about 12 million individuals with blindness as against a total of 39 million. So all these numbers were actually kind of challenging us and saying that why that country, developing country like us, that we have such a large share of a vision impairment or blindness. And also like the fact that 75% of this is actually avoidable and these people could have been spared the misery is something that we learned from you all. And that actually made us think that there is some kind of an urgent case and we should actually start focusing on that. That's how we started. And when we started on whatever blindness, like Mr. Tulsa had mentioned, like many things that, in focusing on supporting secondary eye care hospitals, tertiary eye care hospitals, with many medical equipments to build capacities in all these hospitals. That's how we started. And then we also realized that we also need some focused program much beyond that. I mean, because it's not just about only the share of blindness, the share of vision impairment is quite high. More importantly, even the child blindness, right? The childhood blindness, who are actually born blind and going to become blind for their life, and it's actually pretty treatable and fixable right at the early on. So the things like you all educated us on retinopathy of prematurity to the primary care that Sarah talked about. Now, how important it is actually moving from a secondary eye care to tertiary eye care to actually the community health, particularly putting vision centers in the remote areas. So we kind of moved along with that and started expanding and we also started coming up with some specific areas we wanted to focus within that. So we started focusing on blindness for neonates and children in particular. So that's why our ROP and school screening and programs like that started. And also for the general, the vision centers for taking the eye care actually to the closest to the rural areas, if not at the doorstep, at least closer to the rural areas. So that's how we started. And then once we started our focus, being a technology company, always we wanted actually to do our processes right. First, now, how do we identify the cost was very important. And second, that how do we go about and identify our partners? And thankfully for us, that very, very well established players like Aravind, LVPI, Shankara, all these are have actually solved the problem, and not only by providing these services at an affordable cost and making it accessible, but also kind of fairly reasonably sustainable, a kind of a cross-subsidized model where a few people are paying for the services and others kind of, those who cannot afford, it's actually made affordable for them and so on. So we started seeing that what is that we need to do in that space. And definitely being a technology player, we wanted to see that definitely technology can play a big role in that. We started identifying not only NGOs and partners, also some technology partners. So sometimes we work with them directly and sometimes indirectly. And Forest Health was one of the IIT incubated company. We started working with them, and along with the different versions of Trinetra Classic to a Trinetra Neo, we were actually working and supporting for many hospitals, not only the people who are in this panel, like many remote hospitals in Karnataka, remote hospitals in Pune, Maharashtra. It started with ailments like cataract, glaucoma, and then extended to chronic things like the glaucoma and DR and the various other things. And definitely what attracted us, that like Sir said, it's one can be operated by a trained technician, but also can using the teleophthalmic, it can actually be used from the tertiary cancer center for experts can actually participate in teleconsultation and so on. So that's how it's getting used in some of our vision centers and across the different states. And second, we also realized that it's not it's not just on the eye care. Of course, we also work on healthcare and other areas. One of the other learnings that we had was that beyond this retinopathy of prematurity and screening for these kind of ailments for babies, we also started looking at that why it's happening. Probably the women and child health is important. We need to actually for save the babies. So we started focusing on neonatal health in general. We were working with a lot of neonatal intensive care units and special neonatal care units, as it's called in Tamil Nadu. We started working with a lot of them. And we also started working on women health in that sense, their adolescent health and nutrition and so on. So as part of one of that program, we also identified another startup that was coming from IIT Madras. This time we started working directly with IIT Madras, where it's again an incubated company. This is just the temperature monitoring technology, but where it's kind of connects through IoT devices, actually sensitize both the parents and as well as the ASHA workers, the AHNs, and as well as the NICUs from where the babies are discharged. So for a post-discharge baby, using the temperature monitoring, trying to provide some emergency warning and so on. So we realized that this is actually not yet completely, the processes are not yet validated. So we moved one step, not only for the validated technology and processes here, The technology is matured, it's approved for use, but we were also kind of doing a program along with IIT Madras to kind of validate the processes and make it mainstream as part of government adoption in NICs and so on. So that way that we started moving, like from one, first identifying the technology partners. And we don't work directly with only the technology partners because we do find the importance of multiple people collaborate together. We started working with tertiary care service providers, and we started working with people like you, Ms. Kurian, like the Mission for Vision, like a lot of people, couple of other not-for-profit partners who kind of kind of solve this problem or challenges globally and who have global experience as well. And we try to come back with this multi-party collaborations because we see that we can definitely maximize effectiveness and impact through multiple people coming together. So at one end, the technology partners and so on. We also started, like when Ms. Tulsiraj was talking about this DR and the artificial intelligence, we started some of using our own technology experts, some proof of concepts. And later we realized that, Arvind is working along with Google on those directions. We were so happy. Of course, we were doing our POCs and so on for DR. Again, for a Karnataka-based hospital, we were looking at the data and so on. So there's a lot of potential. One, from a medical devices standpoint, how technology can be leveraged. You talked about big data, machine learning, AI. So one, from the medical devices standpoint, that's the examples that is shared about the Forest Health and the Elixon, that is IIT incubated company and all that. So where the devices level, that it's one end. The other side that we also started looking at it is like, also, how do we, for the patient care and then these, the electronic medical record and integrating it all. So today, if you see, we talk about tertiary care and secondary care, as I rightly mentioned, accessibility can completely be solved only when we are actually strengthening our primary care and eye care. And of course, these technologies at one end making it affordable, and accessibility also we have to improve, and we also have to improve the awareness, because when we want to put the ownership on the patients, obviously they need to be aware. India is today that people are still, okay, it's only chalta hai, it's like, if I'm not, if it's age-related complications, yes, as an age-related, it will deteriorate. It's kind of, it's treatable first, need to we get into the people's mindset, and it should be accessible for people in the remote areas. And even if they are treated, one metric that we strongly keep asking them is that, okay, they come for screening. How many of them went for the follow-up to the secondary care? How many of them get treated? Of the people who are recommended for the secondary care and tertiary care, how many of them really turned up, right? So that is a data that, yes, we do get the data, because we believe strongly on that end-to-end, connecting the data and ensuring that the people are not getting dropped in between. But we see many of our partners are challenged in that, in the sense, all these systems as we see it seem to be pretty siloed. Like the vision centers have their own, system for tracking, and secondary care system centers are having their own tracking systems, and it's all data is getting passed in between through Excel spreadsheets and multiple Google forms and so on, which is fair enough. At least there is a process in place to track all that, but it's still not a very seamless, interoperable system. So coming from an IT field, we always feel that this is a problem. As I mentioned that, we are hungry for problems. We always see this as a problem that can be solved. But for that interoperability to happen between multiple these systems, first the processes need to be standardized. One thing that we see as, that I am moving on from what is available and what we have been doing to what I feel it's like very much required, but it's kind of, we don't see it, like very prevalent across, maybe the others can actually touch upon that. What we see is, we see it within an LVPI, within a Shankara, within an Arvind, it's probably happening. Because if you have your own primary care, secondary care, and tertiary care. But India is not made up of only these major tertiary care players who are having this primary care services extended, right? It's like there are so many who are actually the government, the private, it's operating across India. So if you want to connect with all of them, and they have their own siloed system. So that's what we see. And then this interoperability is a big challenge. And the second thing, that it's not just about interoperating all these systems. I also see the processes are probably not necessarily standardized, because that's an important factor for, these kind of an integration on this interoperability to happen between this. The other area that I see, this is something that, is close to us, because we work with, in healthcare also as a space, as an IT organization across the globe, data privacy, right? India, when it comes to technology production, No, definitely, and even in adoption, so it's a fairly reasonably good adoption, but it comes to completely making it integrated with all these siloed players, and as well as having taking care of the data privacy of the patients. That is equally important. Many times we keep insisting on, like, of course, we also want our projects to be projected, all our good work to be projected, all your good work to be projected to kind of promote the cause of it. We keep asking for these good stories, cases, what happened, and so on. Many times we get photographs, we get names, but not necessarily masked. Okay, I mean, we do a lot of data cleaning on that to tell that, okay, this name is masked, this face is masked, images are masked, and so on. So data privacy is another challenge. I feel India has to go a long way in addressing that, because technology is great to use to solve the problems of access, to solve the problem of awareness as well, and to solve also the problem of affordability and provide that comprehensive care that I was talking about. But we need to address these kind of smaller elements in it. So with that, I'll pass and probably take it in the Q&A.
Thank you so much, Ms. Natarajan. It's amazing to see, your appreciation of the sector. So thank you so much on behalf of the fraternity. Thank you also for taking us through, the journey of Cognizant Foundation's mission, how you identified eye health among various other priorities, trying to understand why there's so much of avoidable blindness and what is the solution towards that, and how you're able to cross the entire spectrum from tertiary eye care, more complicated situations, to appreciating the value of primary eye care. Thank you so much. And I think data privacy is something that we really take for granted. We don't assume that. We often forget that the people whom we serve are individuals who may or may not like their details to come out in the open. We forget that. Thank you for highlighting that as well. Thank you so much. Mr. Bharat Balasubramaniam. Mr. Bharat Balasubramaniam serves as the President for Operations at Shankara Eye Foundation. With a master's degrees in computer applications and hospital administration from Tata Institute of Social Sciences, he has transformed the community outreach process at Shankara. He has been instrumental in introducing standardized systems and technological innovations in equal measure. Under his leadership, community eye care at Shankara stands to be recognized for its consistency, quality, and scalability. Bharat, we look forward to knowing more about your innovation with technology in managing multicentric eye networks with the service approach. Thank you for joining us.
Thank you very much for having us here. Special thanks to Mission for Vision and Elizabeth ma'am for setting this up. I think it's the right time that we discuss on technology, and also thank the panelists for setting the context so that it enables me to talk about what I have enlisted. So I'm going to be talking on the front where we're looking at technology as an enabler at Shankara. Our experience so far that we have over the last few decades, where we realize the relevance of technology and how it has been impactful. Shankara is a network of 11 eye hospitals spread across 8 states, and we also have 2 hospitals in the pipeline coming up very shortly. So we feel that technology is the invisible link which integrates all these network hospitals. So we have looked at technology as a big boom. India being India is spread across, and every state is different, the culture is different. I think the biggest advantage that we have had so far is the technological innovations that have enabled us to standardize processes, that have enabled us to reach out to more and more people across the country. I would like to set the context in terms of the dilemma that any hospital undergoes. We saw Tulsi sir talk about community primary eye care solutions, and we also heard ma'am about data security and data integrity issues. So from a hospital perspective, what are the dilemmas? How do we look at technology? We always look at from a service delivery point of view, but there are a lot of other back-end activities also from a technology purpose. So earlier we were all dependent on client server models. We had only one hospital, and we had it all connected to a server. Then we started, once replication started, web-based applications started coming into picture. So wherever you are, the patients could move from one location to the other, the doctors could move from one location to the other in terms of use technology. And also subsequently, in terms of having in-house servers, we started investing on significantly on servers. But then subsequently, the cloud server technology came in, so we had to adapt to that. Primarily because in order to keep ourselves updated, look at all the upgraded versions of softwares that we would be using. So we had to move into a cloud server-based technology as well. And then again, this is organization dependent. So do we look for a one-stop solution which would enable us to use technology, or do we look at customized smaller softwares which would enable us to reach out to? So we fit into the second mode, where we've taken up the best practices in varied industries, not just in eye care, but varied industries, and that has enabled us to review, monitor, and also ensure that scale could happen. So for any organization which is looking at scale, we would recommend look at technology which best fits you in terms of either a one-stop solution or a customized solution. That's purely based on what the need is. So the decisions that have been taken have been based on assessing the need. What do we actually want? Are we looking at scaling up at different places, or are we looking at one hospital where we would be providing all the services? Identifying the right partner also is key. So like CTS, there are varied number of players who are also equally conscious about the purpose for which we are all here, trying to ensure that we reach out to the doorstep. So identifying the right partner when we are looking at technology association is very key, and having a strong internal team. Again, this is purely based on our experience that we were sharing, that having the strong internal team ensures that the integration between multiple solutions is seamless, data transfer also is precise, and there are no delays, and implementation of new technology also becomes a big advantage. So basically, if we were to give a structure to the different elements what we look at from a technology perspective, we believe that the core is the hospital management solution, the HR management solution, which also handles your payroll, the EMR, of course, in terms of that is the heart of the organization, and email and collaboration tools. Especially post-COVID, we feel that the email and collaboration tools have been significantly utilized. So when we're looking at defining the structure for an organization using technology, we feel from a healthcare perspective and an eye care perspective, these form the core. Subsequent to the core, sorry. Yeah. So moving behind the core is a stronger engine which takes care of the inventory, the procurement, the finance and accounts, the facility management, and asset management. So once the organization starts going beyond our view, our purview, we have a certain area we can monitor, we can control. But once we start expanding and scaling up, these departments, these functions become very, very critical. And to have these core engines ably supported, we need to ensure that the right technology is used, and ensure that a central procurement function or a central inventory management function and the finance and accounts, which looks at all the day-to-day collections and things like that, are all managed centrally. Or again, depending on the need, whether it should be done centrally or decently, again, it's purely on the organization's demands. The front end, which becomes again important, is the patient feedback management. So beyond the HMIS, we need to also ensure that we get adequate feedback from the patients. So how do we make it seamless? How do we make it real time? So we built capabilities so that, at any point in time, if any patient is dissatisfied, it is immediately escalated to different levels in the organization. We also have to deal with multiple transports and vehicles moving up and down for our outreach activities. So bringing in capabilities to manage fleet, where we know, okay, is there a hard braking? How is the mileage? What is the driver's capability of producing the mileage? All those things can be monitored if you have the right technology in place. And we also built something very specific for our own needs, which is the Shankara Electronic Remote Vision Information System, which I'll be talking to you about in a little more detail, which ensures the field workers' performance in the outreach activity also is monitored. We also need to have to ensure we have a strong, stable donation management solution, which ensures that every penny that gets donated is ably reported back as well. So these all form the front end for the organization. And when we look at the pyramid, so we are all used to the pyramid structure. So I thought I'll just share this as a pyramid: the core, the front end, and the back end. There are different layers of the MISs, the reports that get generated from your front end, from the back end, and the core, which can be brought into dashboards to monitor as to what is going to be your key performance indicators, what are we going to be driving it on a regular basis, and then subsequently throwing up analytics as well, which will enable us to take decisions. So that's how significant for us the enabling technology has been. So most of our decisions now are based on the analytics and the information that gets reported, and that helps us to do a lot more things more efficiently. Looking a little more on the service is a handheld Android app that we again built it. So the intention to share this is to instigate people to give you a thought that, nothing is impossible. And if we can do it, anybody else can do it also. So these are all small measures. We know it best. So each hospital knows it best, and they can themselves identify the right partner, develop what they want to do, and put it in place as well. So that has been our experience, and that's what we would want more and more people to understand, that let us not assume that technology is something beyond reach, or technology is something which is too expensive. There are a lot of applications available which we just need to access and sort of build it together. But primarily the need, what we want, only we know. So we are the best judges of what we want. We should be able to build it up ourselves. So this application helps us to, the field workers earlier used to carry a lot of sheets. They used to go door to door. So with this application, we've seen that the productivity has doubled. So they just carry a tab, and 50% more coverage per day. The reach per day has also gone up, and more efficient than manual data collection. So once the paper-based records come in, it kind of becomes redundant. Somebody has to either do data entry into the system, or sometimes it just lays around there. But with this information, we are able to do a lot more analysis and a lot more insights. So for example, we are able to monitor the field workers' performances. So we are also able to compare the field workers across different locations. So one from Krishnankoil, one from Guntur, and one from Kanpur. So they have been rated as the top 3 performing field workers from across all our locations. So that's the benefit that this technology provides us. Also, we are able to look at a heat map, try and understand where we could do targeted interventions, where we should be focusing more of our outreach programs, what should be done, so that we can reach out to more and more deserving people who are needy for any intervention. So this again is something that the service application provides. Moving further, what we've also realized that a lot more jobs and a lot more activities can probably be streamlined if you are able to introduce robotic process automations. So one such initiative was what we initiated, the Cefi bot, which enables us to run the payroll processes. We have about 2,000 employees across different locations. So this bot runs, and whatever process was taking about 240 man hours has been brought down to 3 man hours per month. So that's how the time, how much of time the redundant jobs can be reduced. Excel sheets brought together, and then they are validated, and logic is factored in and uploaded. So that's how simple things have become. Bots have become the rule of the day. Robotic process automation, intelligent robotic process automation is something that is also coming up. So organizations can explore, try and understand or review where there is potential to reduce mundane jobs. These people can be used for more efficient and more intelligent jobs. So wherever mundane jobs can be reduced, again, it is up to us to identify such areas and introduce these bots. The backend, which I said, also has to be very stable. So we need to ensure that the inventory, the central procurement, the procurement part, everything gets tracked, and also ensuring that the purchase orders, the purchase returns, and various combination of activities are all taken care. But it is more important that the vendor is enabled to upgrade the solution as time goes by. So we know that 2 years back, app-based initiatives were not as significant as it is today. And it is the rule of the day. So we need to identify vendors who could provide us with solutions which are in line with the latest innovations and latest what is the new norm sort of a thing. So that's again something for us to keep in mind. This is our backend, which is reliable, and also it's enabled us to scale. But beyond technology, what is even more important is to not just get driven by data and sort of get lost under the data. So we need to also ensure that we have some measurements in place through key performance indicators and setting our annual plans and goals, and also tracking them through balanced scorecards and at different levels. Starting off from the lowest level to going up to the topmost leadership level. So just data alone is half the job done. It's more important for us to monitor it on a regular basis. So this is again data has enabled us throwing up numbers and insights from different locations all grouped together. Again, can be sorted out period wise, can be compared last year wise, how are we quarter wise, and all those things. Again, this we've been able to do it primarily only through technology. And finally, what are the lessons we learned? How did we go about it? Our experience is that we need to align the strategies of our technology initiatives to the organization's vision. So where do we want the organization to be in 5 years' time? And also take our strategies of investing in technology in line with our vision. Set goals, be it short-term and long-term, based on all our capabilities, based on the funds that are available, based on the resources that we can garner, and all those becomes important. And then develop, again, internally, we are the best people to develop it ourselves. Develop measurable performance indicators. What do we want to monitor? How do we want to monitor? So that part, we need to set it up. Integrate people, process, and systems. So people, the biggest change is managing people and the introducing new technology. So we need to integrate the people, process, and systems towards this common goal. Finally, invest in the appropriate technology, measure, monitor, and improve continuously. So this is not a job which will be done once you are done. We have to do it on a daily basis, every day, new things are coming up. So we need to be conscious of that front, but at the same time, look at the returns that are going to be coming up from our investments. So with this, I would like to thank once again Mission for Vision for the opportunity.
Thank you so much, Bharat, for sharing with us a very, what would I say, a very, very admirable way that you go about integrating, whatever you do within yourself and with the communities as well. All of this enabling to enhance the impact and scale what we do. Thank you for sharing with us how you've learned and adapted, not just on the basis of the learning from within the sector, which most of us do, but also looking externally for expertise. That's so important. And more important, the importance of integrating the people with the process and the systems. Thank you very much. Mr. V. Rajshekhar. Mr. Rajshekhar is the Executive Director of GPS Eye Care and has been with the LV Prasad Eye Institute for over 2 decades and is a key driver in the development of LVPI's rural eye health model. He has been instrumental in developing this approach across LV Prasad Eye Institute and its partner networks, and was honored as Eye Health Hero by IAPB in 2012 for his immense contribution towards rural eye care. He advises many other NGOs, including us at Mission for Vision. Primary eye care is a pillar to people-centric, holistic eye health care, as the previous panelists also mentioned. And Rajshekhar, we request you to enlighten us about LVPI's experiences with technology-enabled primary eye care services. Thank you so much.
Thank you, madam. Yeah, good afternoon all. Once again, I would like to thank Elizabeth Madam and Sabitra for giving me this opportunity. Also, it's a privilege to present in presence of Tulsiraj sir and Mr. Bharatji and also Rajashree Madam. The next few minutes, I'll be sharing our experiences in utilizing the technology at our Vision Center network. The outline of my presentation will be, I will give a brief overview of our VVC model and using our iSmart application at our Vision Center network. And more recently, we have launched a futuristic Vision Center. I'll give brief overview and its functions, and finally the summary and way forward. As on date, we have 196 Vision Centers in our network, of which 124 are in Andhra Pradesh, 56 are in Telangana, 13 are in Odisha, and 3 in Karnataka. Our model we have secondary center network, and for typically each secondary center is connected with 10 vision centers, and each vision center is supported by 10 vision guardians, and they undertake various community health activities. All these constitute a village vision complex. One secondary center, 10 vision centers, and 100 vision guardians covering a population of 500,000, providing directly service to 200 villages, taking care of 90% of the blinding eye diseases. So a few years back, when the institute decided to go for digitization, our EMR department in-house developed a solution called iSmart EMR for our rural eye care network. iSmart application is a tablet-based application wherein vision technician at the vision center captures all the data, both clinical and non-clinical. In clinical, all the clinical findings, treatment recommendations, and in non-clinical, all demographic details of the patients are captured in this tablet. So this is tremendously useful to streamline the entire process of our VC network. We have a data and we are using of data for various effective use of our services. And this app is very useful in real-time monitoring of our vision centers. We can track the data, we can know in which location, how many patients are checked in at a particular given point of time, how many are waiting, how many are in emergency, how many of them are needed immediate service is very much useful in this data. And also, this data is very much quickly accessible in a click of a button, whatever the data we needed with the use of this application. And more importantly, all the center data can be found in one sheet. We can compare, analyze, and have a trends of different vision center in our network. And also we get daily automated reports, whatever the key KPIs we developed. If you see in the slide, we can know the source of patients, from where they are coming, the visual acuity status, the IOP status, and also how many prescribed glasses, how many advised surgeries, how many are referred to the next level. Apart from this, this application is very much useful in measuring the coverage also. We know in our vision centers are coveraging population is 50,000. In 50,000, and what percentage of the population is coming in each village, we can track and we can know the impact of that vision center with the use of this application. And above than the data, this tablet, simple tablet, is also used for our teleophthalmology services. We have well-trained vision technician who can capture the anterior segment image with the help of slit lamp and then send to the command center at Hyderabad. Then the doctor there can review the data with the image and send back the treatment recommendation. And also more recently during the pandemic, we are using this tablet for remote monitoring also. We developed a digital surveillance center at eye care in Hyderabad. All these vision centers are connected to the video conferencing facility to Hyderabad to this tablet and to this app, and the manager sitting in Hyderabad can directly virtually monitor the each vision center location. Mainly we are focusing on this protocol compliance, the clinical audits and dispensing of glasses, how many are delivered, how many are pending, and also the referral compliances, and also the teleophthalmology thing. Because our travels are restricted from Hyderabad, so this is very much useful with the app and video conferencing facility. They use TeamViewer or also Skype Lite and also video chat, directly viewing, virtually monitoring the vision center across our network. So over the years, our conventional vision centers proved to be time tested and very successful at no cost at their doorstep, and providing low cost spectacles, and also have strong linkages. But still there are challenges. Referral uptake is a problem because lack of felt need, and also the complex conditions, seriousness of the problem, and lack of felt need by the patients. With this, I think recently, just early this year, we have launched Futuristic Vision Center. It again with the support of in-house innovation team and also with the Standard Chartered Bank, we have come up with Futuristic Vision Center. If you see in the conventional vision center, we have a trained vision technician and an equipment slit lamp with ablation tonometer, refraction set, and having a dispensing of glasses with iSmart. Whereas in Futuristic Center, we added few pieces of equipment like folding phoropter, wherein it can give faster refraction, do faster refraction and give glasses. And we have another equipment called OM, ocular of morbidity. This is a folding, this OM device is used as a portable perimetry and detect the glaucomas, and pupil plus, which can detect pupillary defects, and fundus camera. These 4 equipments plus the standard conventional visual equipment constitute the futuristic vision center. You can see here again trained vision technician taking the images with the fundus camera and the glaucoma findings and sent to the command center in Hyderabad. There, the doctor reviewing the report along with the data and finally giving the treatment recommendations to the vision center back. So if you see the conventional vision center, we predominantly used to do vision test, refraction, and anterior segment examination, where we can detect and correct refractive errors, where we detect and refer the cataract and conjunctivitis, but we can suspect and refer for glaucoma and retinal conduction. Whereas in futuristic vision center, with the addition of these new pieces of equipment, we can strengthen the teleophthalmology network, but we can also detect and follow specifically for the glaucomas, and all post-operative care can be tackled with the futuristic vision centers. We'll continue to detect and treat the refractive errors and also can provide medical interventions, medical services we can provide here. And we can detect and refer the cataract and other surgical interventions to the next level. But more importantly, we can detect and reassurance to give the reassurance for the patient with a definitive diagnosis with this model. If you see the conventional and futuristic vision center data, the last couple of months, so if you see, we did 30% of teleconsultation, we could able to reduce the travel of 16% of the patient who could have provided service at their vision center itself. And we have given 9% of the e-prescriptions were given. And our 1% of the glaucomas are identified with the home device, and another 1% with the fundus, diabetic retinopathy issues. So advantages of this model, it complements to teleophthalmology, supports vision technicians for more definitive diagnosis. It is skill-based to be more objective, whether normal or abnormal, and bringing subspecialty care within the primary care at vision center level, and bridges the geographical distance between the primary and higher levels of care. Also, it does early detection of complex eye conditions and reduce the number of referral sites, as I mentioned earlier, and which is substantial savings to the patient, which can improve the uptake of services and also the decline in burden of visual impairment over time. So in summary, our conventional vision center used to have function. We have 3 functions of it. That is recognizing potential eye problems, doing refraction and dispensing glasses, and referral services. But whereas the futuristic centers, we added 3 more, where we are giving reassurance for the patient with the definitive diagnosis and taking care of all revisits, mainly follow-up care for glaucoma and post-operative care, and providing treatment, not only glasses, but medical services also, medical interventions. Way forward, we think primary eye care with teleophthalmology is the way forward as a part of an extended OPT within the SC network. With the evolution of the technology with portable autorefractometers, portable fundus cameras, with tab-based EMR, then we can go to at the doorstep of the community. With that, we can see there are several advantages, provides needless travel, it can decongest the eye hospital and better compliance, especially for the chronic eye disease. Thank you very much once again to Team Mission for Vision and our fantastic team at LVPI and all attendees. Thank you very much.
Thank you so much, Rajshekhar, for that wonderful overview of demonstration of how you can improve the efficacy and efficiency of primary eye care solutions at the LV Prasada Institute network of centers. Thank you for also sharing with us how technology helps in measuring real time the performance and the impact at each of your centers and also bringing it together centrally. Technology has helped manage not just the basic eye conditions that we nowadays take for granted, like cataract and refractive error, pardon me, they are still the major cause of blindness. But you have shown us how technology can address the most complex of eye conditions at the primary level. And that makes it so much more convenient and affordable for the people for whom we exist primarily as an organization. LV Prasada Institute has been a pioneer as far as primary eye care is concerned through vision centers. And during this pandemic, you have more than amply demonstrated how the Vision Center network has been able to reach out to communities in need so wonderfully. Thank you again. So, can we move to the question, answer, and discussion set? Can we have the panelists, please? Can we see them? Thank you. At the outset, I would like to express the appreciation and the congratulatory messages that have been coming in through the chat messages to all the speakers here. Thank you so much for the valuable lessons that you shared with us, all the learning and the experiences, and also charting the way future for us. There are a few questions. One is to Mr. Tulsi Raj. There is a question as to how the investment into technology can contribute towards sustainability of vision centers at the primary level, Tulsi.
I'm assuming the sustainability, is it around financial, you think?
I think both. They are meaning both. This is a question from the state of Bihar.
Bihar, okay.
Yes.
Okay. Can I quickly show a slide?
Yes, please.
Yeah, so that just to illustrate that.
Yes.
Okay. So just as an illustration, I'm taking one of our secondary hospitals, Theni, which has got 7 vision centers. So this whole thing of viability, both financially and operationally, is very intertwined with scale. For instance, these 7 vision centers that are in Theni, they contribute to about 1/3 of the total outpatients, seen by the hospital and the vision centers together, and a little more than 1/4 of all surgeries. And each vision center, on an average, sees about 10,000 outpatient visits a year, contributed to 320 cataract surgeries, some of them done free, some of them went to the paying side. And about close to 1,400 spectacles. So this is the quantum of work, and I think viability is based on this. And then when we translate this into financial, these 7 centers together earned about 6 million rupees, 60 lakhs. Expenditure was a bit less than that. So I would say they kind of break even. But then in addition to this, without the vision centers, the 2,248 surgeries that happened would have happened largely through ICANs, if at all. And then, so there is a definite cost saving. I think all of us recognize that to bring a case from an ICAN, it costs money. And in our case, in Theni, which is very small district with small distances for traveling, even there the case finding cost is roughly 360 rupees, which means about 8 lakhs of rupees saved, and this is real. And then of this 2,000 odd patients, 940 patients became paying patients, which means on each surgery that we did on them, we would have saved a certain amount of money. And that is not trivial. That works out to about 33 lakhs is what we estimate as the additional bottom line, that is the savings. So overall, the answer is yes, it can sustain. But then the other part of sustaining a vision center operationally is to get organized on the support side, in terms of, because every morning, one of the CMOs will get a call saying that in this vision center, the technician is calling in sick. So if you don't immediately act and send a substitute, rush someone there. You'll have to close down the center. And then when you have, in our case, 80 centers, at least 5, 6, 7% of them, maybe like 10 centers on a daily basis, this will be an occurrence. So we need to maintain continuity of care, which means we need to have people on the bench who can be rushed to do the staffing. You have issues with technology breaking down, supply chain breaking down. So this whole building up the support structure, because these vision centers can't exist by themselves, because they have they're extremely lean operations in terms of everything. Now, there is no redundancy there at all, by design. So operationally, you have to recognize that and then build that slack in the base hospital. And then you have to have processes to be able to do that. And if you don't do that, then you fail because if you are closed 2 or 3 days in a week, then you lose credibility in the community. And people stop coming to you. So I think both it is possible, but I think it takes effort. You can make it work financially, and you can also make it operationally viable otherwise.
Thank you so much for that affirmative and encouraging response, Tulsi. There is a request to Rajeshri to sort of guide us. I mean, I know it may be a very broad sort of a suggestion, but what is the first thing that we need to keep in mind when we think of patients' rights and their privacy? To all of us organizations who take it for granted in our excitement, see, we are excited and enthusiasm to do more, but we forget about their rights and privacy.
So actually there are data privacy laws, globally. If you just kind of start our compliance towards it, that's a good starting point. I mean, of course,
Right.
Even in most of our places, like in all countries have data privacy laws. So data security, data privacy laws exist. And of course, there are variations. When I talk about electronic medical record, that who owns the data? Is it the provider? Is it the patient? And, like that varies. Even in a very, very well-developed country like US, to get access to your own data is difficult. It's not that easy. It's there, the provider and so on. So there are variations across the countries and various across the providers, but there are standards that exist. I think if you follow standard, that's a good starting point. But as a thumb rule, right? We don't have any right to kind of expose the names of the people, the faces and the images and things like that, whatever we do. And if we have to do it, just to be with a prior permission is something that as a bare minimum that kind of we put it across. And actually, as Bharat mentioned, right, he also talked about, data integrity issues across the different silo systems is also complicating it, because it's not automatically like one system. All the good systems that we heard about in LVPI, and as well as in Shankara, or as well as in Aravind, right? It's a same entity, it's the same organizations. You have to understand that the tertiary care, secondary care, and primary care is all the same, right? It's under the same management. But in reality, Ms. Kurian, you know that when you're working with multiple vision centers. Absolutely. And multiple smaller secondary centers who do not have that scale, right?
Yes, true.
So is it that these systems, I mean, every time that we used to keep asking you, saying that, can we take one of these best and implement it across India? But that's not something that we're seeing it happening, right? I mean, there are a lot of siloed systems that as we see it, and people still struggle to feed the data. And the moment the data gets fed through multiple, broken channels, then it's kind of aggravates the problem, So it's a simpler thing is to get it kind of seamlessly integrated one, and definitely take care of, like securing the data with the right permissions, the roles and responsibilities. So those who need to have access, but otherwise it needs to be, like completely sealed off for others to view and so on. And plus anything that goes in public, right? I mean, I've seen, I've had doctor cousins, and I've seen a lot of videos, surgery videos and others, which doctors need to use it for the knowledge sharing and collaborations. We have, as part of our knowledge management portfolio, we've developed a lot of, in my earlier avatar, we used to develop a lot of those where the knowledge sharing is important, collaboration is important among the medical fraternity, but we'll have to also understand the privacy of the patient is important. I mean, we have to do that without violating those rights. I think if we simply follow the standard laws across the country, I think that's a good starting point.
Thank you so much. I think it starts with that and for your helpful response to a rather complex subject. Thank you. Especially in a country like ours, where sometimes we think of it as privacy, but sometimes patients are very happy to be the face of
It's true.
a campaign.
That's why I said with permission.
Yes,
Yeah.
absolutely, absolutely. Thank you so much. Bharat, there is I don't know whether this is a question for this particular forum. The question is how technology has helped in the growth of Shankaraya Foundation over the past 20 years in terms of, if you just look at it in terms of the scale that you've arrived at.
Yeah, the question is how it has helped in terms of
How technology has helped you scale. I think you've already
yes.
sort of told us how it has, but if there's something further, they just want to understand over 20 years how it has helped you.
Yeah, so yeah, we started with very small initiatives, and today all the hospitals are integrated, and data is seamless across the network. So I think without technology, I don't think we would have it wouldn't have enabled us to scale beyond one hospital. So I think that's how significant in Shankara's experience technology is and will continue to be.
Thank you so much. Rajshekar, there is a request from organizations for understanding how to get training on iSmart EMR and the establishment of futuristic vision centers. And there are also there's a request for training of for other centers, organizations, in how to establish such vision centers. And also there's a question on the cost of setting up a futuristic vision center.
Yeah, training. You can give the details training. Already we have working with other partners in the our EMR support and other thing. You can provide the details of the concerned department.
Sure, if you need more time
the cost of the futuristic vision center depends upon the equipment. We are spending around 16 lakhs per center. 16 lakhs.
Okay. Thank you. If I could request Tulsi to share his vision of a technology-enabled primary eye care, say 10 years from down. What would you see, Tulsi? What do you see 10 years from now as far as primary eye care is concerned?
Yeah, my vision of primary eye care, which I think can be a real possibility, is that it will kind of turn eye care upside down. In the sense for giving, because as the care becomes more chronic in nature, and also as we get increasingly focused on ensuring compliance and things like that, the secondary and tertiary hospitals are not equipped to do that, because they can at best be reactive. So what will happen is the primary care is what actually can make sure that tertiary care happens well. I'll give you some numbers. For example, we have been tightly monitoring the compliance for follow-up by glaucoma patients. And we know that over time, the disease progresses or the risk increases. But then what also happens is over time, the compliance rates drops dramatically. Like say in the second year, probably 70% of them show up. And by the fourth or fifth year, about 10% of them show up, from the cohort that was identified, say 5 years back. So, but then when we did something in the vision centers of building a registry for all glaucoma patients seen from that community, and then track them, and then we're able to monitor and reach out to them, we were able to keep that follow-up rate from about 10%, take it up to 40, 45%. Okay. And we know that those patients who are not coming for follow-up, the disease is going to progress unchecked, and they're going to face the consequences. And ultimately, all the effort that's put in the tertiary care goes to waste. So I think this story repeats itself. So this is about chronic care management. And again, you will recognize that secondary, tertiary care are not at all equipped to do any preventive work. because they sit and wait for the patients to come. But in primary care, you have that opportunity, and then you can exercise it in many ways. Like, for example, today we put so much emphasis on banking. I personally feel we probably need 1/3 of whatever is projected, as the need, because a lot of the etiology behind a person requiring a corneal graft are preventable conditions, and a lot of that happens in the rural communities during agriculture season, wherein they take on home remedies or whatever. Something falls in the eye, they'll apply milk or blood or milk or something like that. So, and then things get really bad. So if there was a primary care center, they can, and we have done a study. In fact, we've done a multi-country study, covering India, Bhutan, and Myanmar, wherein we demonstrated that a simple application of an antibiotic ointment by a health worker whenever somebody gets a foreign body in the eye completely eliminated ulceration of the eye, needing anything beyond. They didn't. A corneal graft was miles away. It kind of resolved in most cases. So in fact, our referrals to the cornea clinic over the years have dropped dramatically from the vision centers because of this reason. So that is another reason why vision centers can make the care this thing. On a technology front, this is for Mrs. Rajalakshmi Natarajan to see if they can do that. Today a lot of technology is developing to interpret something, like say a fundus image or glaucoma cup or something like that, to say this is there or not, which I think is important. But if they can also go one step further to compare a series of images over time to tell, is a disease progressing or is it stable? And if they can do that, then I think we can shift a lot of the monitoring and the visits that they have to make to the base hospital, wait for that specialist who's, spend the whole day out there. All of that can be eliminated. They just need to go to the vision center, take an image or whatever data you need, and then some algorithm tells. But today everything can be in the cloud, so you don't have to invest on the computing power in the local center. You just need a mobile phone or a tab or a low-cost desktop that can do the work. So I somehow feel that if we do this right, I think whole eye care will depend upon primary care centers, effective eye care, because from universal coverage to making sure the care is effective, I think it is the primary care centers that are much better placed, and it is for us to imaginatively leverage that.
Thank you so much, Tulsi. Here we are fortunate to have organizations who have so much of experience in the area of technology, not just eye health, but technology-driven eye health. But at the same time, there are many others who are still grappling with the term technology. It sounds very complex. It sounds that maybe somebody else can do it. I can't. I am not perhaps smart enough. I don't have the necessary sophisticated infrastructure or team to adopt technology to improve my work. So may I request each of the panelists to please share one key advice that you would offer each of the organizations who have these doubts. How do we help them demystify and step up on technology for eye health care at their respective centers? May I request Rajshekar to please first respond?
Yeah, I think for technology, not just in our case, just having a simple tab with EMR, we are doing a lot in that, using teleophthalmologist sending, as Tulsiraj said, having the cloud, not very expensive, but simple thing. But again, system processor should be there, and having the right training can be done, all these things.
Thank you. So Rajshekar says it's not very expensive. With the right systems and training, we can manage. So it's not that complex. Is that what you're saying, Rajshekar?
Yeah.
Thank you so much for that. Bharat? One or two key messages.
Basically would be to just start small, don't get the technology word is sometimes demystifying and things like that. But start small and keep it simple. Whatever you are taking, take it in small portions, and keeping it simple will help. So that's our experience.
Thank you so much, Bharat. Rajeshri, please.
I will just say don't reinvent and reuse. Okay, because I've heard a couple of other states and major hospitals referring LVPI and Arvind and saying that we are going to take the help from them and we're going to use their IT systems. That made us really happy and feel reassured, to be very honest, because at least they're not reinventing the wheel and reusing it. Technology has a lot more to offer. You can keep grabbing and coming up with new problem statement, but not probably solving the same problem statement and again and again. And collaboration goes a long way there.
Thank you. Partnership, collaboration, working together. Tulsi, please, final words.
Yeah, I want everyone to recognize that the world is more than ready to adopt technology. People somehow feel they're rural, illiterate, they may not be able to deal with technology. And we were so pleasantly surprised way back in 2005, when we introduced telemedicine. It was absolutely fascinating. Bold women without wearing a blouse, just a sari, coming and nonchalantly talking to the doctor, looking at the screen. I mean, it didn't fazzle them at all, the technology part. So I think the technology openness is there with everyone. And I think as providers, we have to remove whatever cobwebs may be there, and somehow I think it is true, not so much to scare, but I think if people don't adopt technology now, then I think it will be as a comparison would be a hospital not adopting IOL technology. So it is a question, it will be almost a survival question, I think.
Thank you so much. Thank you so much. So thank you all. I think it is more than amply clear that technology is a key driver for solutions for health and other social issues and towards the betterment of humanity. The sooner we accept and adapt technology as integral to our lives and work, the more effective we are equipped to be. It's not all that complex. Our advisors and panelists have shared that, we start simple, we collaborate, learn from others, and think big and not to take our beneficiary communities for granted. We are very grateful to Mr. Tulsiraj, Ms. Natarajan, Bharat, and Jayashekhar for their very inspiring and informative messages. Our sincere gratitude to all of the participants for your appreciation, ideas, comments, and questions, and for joining us this evening. Many thanks to Shrikant, Shobitro, and my colleagues at Mission for Vision for planning and anchoring this webinar. On behalf of Mission for Vision, I would also like to invite you to our next webinar on pandemic perspectives, enabling eye health to the very last mile. And this is specifically with regard to the best practice that has been emerging during the pandemic and reaching out to the most remote communities. And this is being organized next month on the 10th of November. And we'll have various partners sharing experiences. Thank you once again. Good evening.
Thank you.
Thank you.
Thank you.
Thank you.